Welcome. My name is Samantha Banerjee, and I'm the Executive Director of Push for Empowered Pregnancy. We are a U.S.-based national 501c3 nonprofit dedicated to ending preventable stillbirth. And I am here today with my team to share with you Pushing to End Preventable Stillbirth, an overview of the U.S. stillbirth crisis and solutions. We've got on our agenda today 4 sections of a thematic panel, the first of which will include our short film, which explores how many stillbirths are preventable, followed by a crash course in the dire state of U.S. stillbirth statistics, and then a deeper dive into the systemic barriers blocking change for Black, Indigenous, and people of color, and finally, a quick overview of some practical tools for prevention. You will hear today from me and several other members of the PUSH team, all of whom have lived experience delivering a much-beloved baby born still. We are here today because we believe that if the evidence-based changes that we are advocating for had been implemented during our pregnancies, our babies might be alive. We don't want any other family to ever have to carry the same excruciating what-ifs that we do. But right now, there are tens of thousands of U.S. families joining our ranks every year. It's time for change, and we hope you'll join the fight beside us. United we push. And now I'd like to turn it over to my colleague Anna to share with you our short film, which is the centerpiece of the award finalists' awareness campaign, Stillness is an Illness. Thank you.
Thank you, Samantha. You're about to watch the short film Push, which is the anchor to our national Stillness is an Illness awareness campaign. It highlights the importance of fetal movement and how simple changes can help save lives. This heart-pumping, provocative short film explores the critical impact of addressing or dismissing stillbirth warnings. Through the lens of a couple in the final weeks of their textbook pregnancy, we experience in real time the series of pivotal decisions that this family and their healthcare team make that, glitching between the parallel universes, lead to 2 very different outcomes. By challenging the perceptions of fate, the film Push encourages families and healthcare providers to rethink our medical systems and society's current standards of education, empowerment, and accountability around stillbirth prevention. We invite you to watch this film not as clinicians, if you're a provider, but as humans. Imagine these are your patients, your colleagues, your family, even yourself. The film is not meant to place blame on anyone. Doctors and providers are victims in this broken system as much as parents are. So please watch with an open mind and think about the impact of this experience on the family and what you would do differently. This short film is based on real life events, similar to what I experienced and many others. So of course it is emotionally triggering if you are a lost parent. We invite you to watch the film with us, but if it's too much for you now, please step away for the next 7 minutes and come back with us as we discuss further how we can prevent this tragedy. Of course, we've lived this, so we don't necessarily need to watch a film like ours, but it does highlight the gaps in care and the critical ways that this family could have experienced a different outcome. So without further ado, Push.
Good morning, Mama.
Baby,
What?
did a squirrel die in your mouth or something? Because you know,
Oh, Lord.
no, I can't give you any more. You stink.
All right, easy up, easy up.
Okay.
You all right?
I don't know. Baby,
Yeah.
something's wrong.
Let's call the doctor.
Dr. Miller's office, please hold. Go ahead.
I'm not sure if something bad is happening or not, but I'm not feeling movement anymore.
A lot of babies slow down at the end. It's not much space for them to move around anymore.
I will have the doctor call you.
Okay.
Okay, thank you.
Okay, bye.
I'm not sure if anything bad is happening or not, but
But I don't feel movement anymore.
Okay. Give me 1 second. Dr. Miller, it's the Hart family. They're worried about fetal movement.
Tell them to go to labor and delivery immediately. I'll meet them there.
Wait, we should come in like right now?
Yes, immediately.
Okay.
Okay.
I think I'm gonna head over now. Can I go or do you want me to wait for you?
Wait for me. I just got one more call.
Okay.
Hi there, it's Dr. Miller.
Hi.
Listen, I want to assure you that everything has been textbook with your pregnancy. You are not high risk.
Oh, great.
And if it makes you feel better, just drink some OJ, lie on your side, and count some kicks. If you get less than 10 in 2 hours, give us a call.
Okay.
2 hours. Okay, got it.
Great.
Yeah.
All right. Bye-bye.
Hi. We home.
Dr. Miller, follow me.
Okay. Okay. Call again. Call again.
Yeah.
You have reached Dr. Miller's OBGYN office. We are currently closed. If this is an emergency, please call 911.
The doctor said not to worry.
I know, baby, but something is wrong. Okay?
Okay, we can go in if it'll make you feel better.
It's late. It's late. Let's go first thing in the morning, just to be safe. Yeah?
Yeah.
You're gonna think we're nuts. Hi.
Hi.
Oh, hi.
We
called yesterday.
Yes.
Wanted to make sure that everything was all right.
Yeah, no, everything's gonna be fine. All right, let's go check your baby out. Follow me.
Okay, thank you.
All right, Mama. You gotta give me a push, okay? Ready? One more push.
Okay, okay.
Big push. Ready?
Come on,
And give me a push. I see the head.
Hold on, Mama. Breathe.
Now that everyone has some information about the statistics and the facts around stillbirth, we want to humanize our issue for you, because 1 out of 175 pregnancies ending in stillbirth is a really shocking figure. But when you are that one, let me tell you, it changes your life. Sadly, each one of us at Push has experienced this tremendous tragedy. So we share our lived experiences so that other people don't have to walk a day in our shoes. We recognize how difficult it was to watch that film. So in a moment, we're going to have a grounding exercise with Marjorie. But we want to get your immediate reactions. So please drop in the chat. What are you feeling at this moment? What key takeaways do you have from the film? What stood out to you? Drop those thoughts in the chat so that we can come together later and discuss. Now let's take a moment to ground ourselves with Marjorie so we can continue to expand our learning together in a safe space. Thank you.
So after watching the film, we understand that some of it may have been triggering for some of you. And so we wanted to do a grounding exercise just to get you back to baseline. So first thing we want you to do is to place both feet on the ground. Rest your hands on your lap and notice the chair or whatever it is that's holding you up. So the next thing we're going to do is we're going to breathe in slowly through your nose. And we want you to imagine calm air filling your lungs. Hold it for 2 seconds. And then we want you to release your breath through your mouth as if blowing out a candle, letting your shoulders drop. So again, you're going to breathe in slowly through your nose, imagining calm air filling your lungs. You're going to hold it for a few seconds, and then you're going to exhale to release your breath through your mouth as if blowing out a candle, letting your shoulders drop. Ready? One more time. And we're going to close out with the affirmation. You can put your hand on your chest or on your heart or on your stomach. And I want you to whisper to yourself, I am here. I am safe. I can breathe. Ready? I am here. I am safe. I can breathe. I am here. I am safe. I can breathe. Thank you.
Here on this slide are photos of our beloved babies and us holding them. This is one of the few moments that we were able to carry them. Now we can only carry them in our hearts. And below we share the cause of each baby's death. This is to highlight the fact that many of these deaths are preventable. Think about each one of these babies and what could have been done differently. Could we have scanned the cord? Could we have measured a placenta? Could we have educated each parent about fetal movement and what a change might mean and how to properly get care immediately? Could you have educated everyone on the team, from the ER who receives a phone call, to tell this parent to come right in, or the front desk to make sure that they get immediate care instead of taking time signing in, getting insurance information? Because we do believe that every baby deserves a fighting chance. And in many cases, stillbirth is preventable. We know that 1 out of 4 stillbirths in the US could be prevented with simple evidence-based tools. As you get closer to term, 47% of all pregnancies lost at 37 weeks and above can be prevented. Think about that. Babies that already have a nursery ready, have clothing washed, pressed, lovingly put away in their drawers, diapers ready. We gave birth to these babies and we had to bury them or cremate them. Our milk comes in, as my shirt says, stillbirth is stillbirth. And I'm actually carrying this bear here whenever I advocate to again humanize our issue, because this is the weight and length of my son Owen when he was born. He could have made it. He just needed to be taken out a little bit sooner. So let's work together to make that possible for other families. This is a quote by Carly Marie that I love. I'm gonna read it to you. Just let it sink in. You were not a lost pregnancy or a stillborn, as some have described you. You were not a sad thing that happened to us or a tragic circumstance. You were a baby, my baby, our baby, a human being, and you still are. Please think about what can be done to make sure that every baby is treated with the utmost care, with every tool available, that we do everything possible to give each family a fighting chance against stillbirth. And of course, we don't want this film to just stay with us. We want to share it. So if you can take a minute here to get the information on the screen so that you can share it later with all your colleagues, with your patients, with your families, with other advocates. Your help in this moment to spread this film can help save lives. So thank you for helping us with that.
Thank you all so much for standing beside us to bear witness to the incredible emotional devastation that is stillbirth. Now that you have a better understanding of the experience of stillbirth, and particularly the frustrating fact that so many of these tragedies are potentially preventable, the second section of this thematic panel is going to focus on some of the numbers driving the U.S. stillbirth crisis. Over 20,000 babies are born still in the United States each year. That works out to, on average, every single day, 65 families bringing home an empty infant carrier from the hospital. Even in the U.S., many medical professionals and public health officials do not realize that stillbirth is actually the leading cause of death for American children ages 0 through 14 per CDC data. For decades, stillbirth has been claiming the lives of more babies and kids than prematurity, SIDS, car accidents, drowning, guns, fire, poison, flu, and listeria combined. And just like any of these other common dangers of childhood, though stillbirth cannot always be averted, there are many things that parents and providers can be doing to lower their risks. Right now, the equivalent of a school bus full of babies or 3 kindergarten classes are wiped out every single day in this country. As we mentioned earlier, research shows that at least 25% of U.S. stillbirths are preventable, including nearly half at term. Despite this reality, expectant families in the U.S. are subject to a cruel double standard that does not warn them about the possibility of stillbirth risk, even though we are routinely educated about other risks which we are much, much less likely to encounter, such as listeria from deli meat and toxoplasmosis from kitty litter. As a result, U.S. stillbirth parents are being stripped of their right to protect their children against this risk, as the lack of informed consent leaves them in the dark, completely blindsided, never knowing that it could happen to them. Needless to say, we have massive room for improvement. Compared to 195 countries worldwide in the past 20 years, the U.S. ranks 183rd in average rate of reduction of stillbirths. You heard that right. 183rd out of all 195 low, middle, and high-income countries that report stillbirth rates worldwide. Looking at only high-income countries, we place 48th out of 49 in the same measure. And if we matched our best international peers, we could be preventing up to 75% of U.S. stillbirths. Appallingly, as we see with other adverse maternal health outcomes, Black and Indigenous mothers and birthing people are twice as likely to suffer a stillbirth. Why? Though many assume this is due to socioeconomic factors or social determinants of health, in fact, recent research indicates that the disparity in racial outcomes amongst stillbirth parents, especially for Black moms, is better explained by systemic and structural racism and implicit bias in our healthcare system. We know this is true because just as we see with mortality and morbidity, education and wealth are not protective for Black families the same way they are for other races. And in fact, a recent study that specifically looked at the role of social determinants of health in driving stillbirth rates amongst different racial groups found that for Indigenous Americans, social determinants explained nearly 100% of the disparity in outcomes. For Black mothers, it explained only half. So what's driving the other half of the disparity? That would be systemic racism. And this, in our view, is the low-hanging fruit of stillbirth prevention. Because if we can close the gap, we would be saving 4,000 children's lives every single year. That, in and of itself, would represent over a 20% reduction in U.S. stillbirths. As you'll hear more about in the next section of this panel, it's critical to understand that when evaluating outcomes across different racial and ethnic groups, race is in fact a proxy for racism. Said another way, if racism didn't exist, race would not be a risk factor for stillbirth. As you may have already surmised, stillbirth is inextricably linked to the maternal morbidity and mortality crisis in the United States. Stillbirth moms have been shown to be almost 5 times as likely to experience severe, potentially life-threatening maternal complications compared to mothers of live-born babies. And this is critical to account for in any program which is targeting improving maternal outcomes. In New York City, for example, where we have some of the most robust maternal mortality data in the country, 60% of maternal deaths have been shown to occur in the postpartum period, 2/3 in those first 6 weeks directly after birth. And given that 900 babies are born still just in the 5 boroughs of New York City each year, that means that the postpartum period is a critical time to ensure that stillbirth moms are getting the support they deserve. Unfortunately, that is not the case right now in much of the United States. In New York, for example, moms who suffer a stillbirth are being stripped of the paid family leave that they were guaranteed and forced back to work during those very same dangerous first 6 weeks after birth, in a very real way, putting the lives of mothers at risk, and particularly the lives of Black, Indigenous, and other people of color. There are many underlying larger systemic issues that are contributing to the U.S. stillbirth crisis. And the good news is that it's many of those same root causes also driving our abhorrent rates of maternal mortality and morbidity. That said, when it comes to stillbirth in particular, one of the easiest things for us to address should be the rampant and persistent dangerous myths that continue to influence the behavior of parents and providers alike. For instance, it is still widely believed across the United States that it is normal for fetal movements to slow down at the end of pregnancy. Parents like me are often falsely reassured by misinformation that we find online or hear from loved ones or even our medical teams that say not to worry if you notice a change in your baby's movements as long as you're in a low-risk pregnancy. A study which just came out a few weeks ago found that half of all Google search results for reduced fetal movement contain misinformation, and that this is primarily being driven by commercial U.S. pages targeted at expectant families. Another study showed that 1 in 5 patients recalled receiving misinformation from their medical provider about fetal movement. So why is this happening? The main reason is the lack of standardization. Both medical providers and the editors of commercial websites are dependent on the information put out by leading U.S. professional orgs and public health agencies, such as ACOG, SMFM, and the CDC. At this point in time, there is no clear, concise, publicly accessible guidelines for either patients or medical providers that elucidate what normal fetal movement should look like, or standard protocols for how providers should be educating patients to monitor fetal movement, or how the providers themselves should be responding to patient concerns. As a result, 55% of stillbirth mothers are never told by their provider about the importance of fetal movement. And those that are often receiving outdated information, like instructions to look for 10 kicks in 2 hours. Furthermore, our standard protocols, even in high-risk pregnancies, are all but ignoring the essential life-sustaining organs of the placenta and umbilical cord. For U.S. families, fetal movement monitoring is one of the only tools at their disposal to help them advocate for themselves and their babies. And most of us are not even being equipped with that bare minimum. And finally, even for those families who do receive some education about fetal movement monitoring, they are almost never told about the potential for sudden, rapid, frantic increases in movement, which might signal the need for evaluation the same way that reduced movements do. The main thing I want you to take away from this section of the presentation, though, is that countries like the UK and Australia just a few years ago were reporting similar stillbirth rates to what we see now in the US. But with the introduction of simple 5-step care bundles, they've been able to reduce their rates almost immediately by 20 to 30% in participating units. If they can do it, we can too. I know I've dropped a lot of numbers on you in the last few minutes, but the thing that's most important to remember is that these are not just numbers. These are our children.
What if every day 65 kids didn't make it to their first day of kindergarten? Wouldn't we want to do something about it? Every day in the United States, 65 babies are born still, like my daughter, Alana.
And my son.
And mine.
And mine. And mine. And mine. And mine. And mine.
Every single one of the 65 babies that we are losing to stillbirth every single day in the United States has a name, had a nursery waiting for them, a family who loves them, and who continues to miss them every single day that should have been their life. Please help us raise awareness by sharing this public service announcement and ensuring that every pregnant family you know is empowered with the information they need to lower the risk of stillbirth. And now I'd like to turn it over to my colleague, Marjorie Vale.
Thank you, Sam. And now that we understand better the dire situation of stillbirth in the United States, we wanted to do a deeper dive into systemic barriers and bias driving the disproportionate rates of stillbirth among Black, Indigenous, and people of color, and of course, other marginalized groups in the United States. Commonly cited social determinants of health place a significant role in inequitable pregnancy outcomes across races, but particularly for Black families. Social determinants of health can only explain part of the disparities. This presentation will explore how factors such as systemic racism, implicit bias, and medical paternalism are exacerbating structural inequities. So let's talk about the impact of racial disparities. Stillbirth rates are double in Black and Indigenous women. And although Black families are only 13% of the population, they account for 30% of the stillbirths in the United States. So why is that? We know that it's a combination of social determinants, right, of health and systemic racism. And unfortunately, being educated or a wealthy Black person, a birthing person, does not protect them from the stillbirth outcomes. So let's talk about barriers to care. BIPOC women or birthing persons have a higher social determinant of health burden. And that comes in 3 ways: individual, organizational, and structural. So let's talk a little bit about the individual. Indigenous, Black, or Hispanic birthing persons have occupational risks, issues with support system or underprivileged upbringing, advanced age, which starts at the age of 24, lower income, or lack of private insurances. So those are the individual social determinants of health that cause a barrier for care. So let's talk about organizational. So if there are delays in provisions of adequate care, if they're in a larger hospital where they can get lost in the melee of people, if the mother or the birthing person needs to be transferred, meaning the current hospital that they're in cannot take care of them, or they do not have the resources to take care of the high-risk pregnancies, those are some of the burdens, right? Organizational burdens that are barriers to care. And lastly, structural barriers. So if you are located in the US South, historically, you're exposed to racial segregation, which is a barrier to care. There are higher rates of poverty and higher ambient temperatures by which heat exposure and dehydration result in placental compromise. So those are the ways social determinants of health are a burden to BIPOC women and birthing persons when it comes to their pregnancies and having a good outcome. When we're talking about racial disparities, we have to think about the roles of the isms, okay? So race alone is not a factor for stillbirth, but racism is, right? And the more marginalized groups that a person identifies with, the more likely they are to experience multiple forms of discrimination. And the more complicated it is to combat that situation. So if I'm a Black woman and I'm queer, right, those two, being part of those two marginalized groups makes it harder for me as a pregnant person when it's time to give birth, or to be heard when I am feeling like something is not right within my body. We have to think about how we live in a white supremacy culture. And what that means is that it's the standard is created and maintained for racial inequities. And what it does is censors experiences, priorities, and values of white people above those of other racial groups. And so these are some of the isms, right, that marginalized people, BIPOC people deal with when they are pregnant, and which creates a barrier to having a healthy outcome for their pregnancies. So looking beyond social determinant of health, this quote says, interestingly, unlike the other racial ethnic groups in our study, which showed a clear increase of stillbirth rates in the presence of social determinant of health issues, non-Hispanic Black patients had similar stillbirth rates with and without the presence of social determinant of health issues. So overall, there's a 60% increased risk of stillbirth in the presence of any social determinants of health, and 54% risk compared to our white peers, even without a social determinant of health. I think about myself. At the time that I gave birth to our son, Alexei, I was a middle-class Black woman, educated, who married into upper middle-class family, and yet still I had the outcome that I did, and that can be pointed towards one reason, and that's racism. And so we cannot ignore the role that racism plays when it comes to BIPOC families and marginalized families when it comes to giving birth. So let's look at how this is connected to maternal mortality. So study after study has shown that maternal death risk is a real thing, especially for BIPOC families. We've all been seeing the headlines in the last several years, right? The risk is very severe. And, maternal complications are 5 times higher for moms who've delivered a stillbirth compared to someone who has given birth to a live birth, right? So maternal complications are the key driver of infant mortalities, okay? And about 5.6% of all infant death in the United States resulted from maternal complication of pregnancies. So when it comes to Black women disproportionately suffer complications. And childbirth is deadly for us in America. Okay. Well, childbirth is deadly, period, but especially more so for Black women. We have severe maternal complications that are 5 times higher in stillbirth moms, and the higher socioeconomic status does not decrease our risk, right? It doesn't decrease the risk for Black families. And so these are important when I think about my own sister who died 5 days after giving birth to her daughter. She had some complications and, really bled out a lot and wasn't listened to in terms of like how she was feeling. And she was sent home 3 days later, and she died 5 days later after giving birth. And so this is a separation in terms of stillbirth, but yet still connected, right? Sometimes the mother's health is connected to the outcome of the infant. Sometimes both mother and child don't make it out, and sometimes mother doesn't make it out, or sometimes the child doesn't make it out. Whatever it is, there's a serious problem in America, and Black women are at the top of the list of those who are suffering the most. So let's talk about other marginalized birthing people, right? Parents from many marginalized or minority backgrounds experience increased barriers to care and or forms of discrimination, which result in higher stillbirth rates and less access to post-loss support. So this can include factors such as identifying as LGBTQ+, right? This includes your sexuality and your gender expression, social economic class, particularly for parents on Medicare versus private insurance, military families, rural families, many of whom live in maternity care deserts. So it can be challenging to get the kind of medical help that they may need, especially if something is an emergency. And lastly, immigrant status. So someone who doesn't speak English or from other ethnic or religious groups can have a difficult and challenging time getting quality of care. Okay. So although, causes are not definitely pinpointed, these groups have shown to have higher rates of adverse pregnancy outcomes from the moment they find out that they're pregnant, through their pregnancy and post-pregnancies. So in many cases, the same underlying systemic issues which drive the racial disparities in outcomes are likely to blame, right? And so I hope this gave you a little bit of a snapshot of what BIPOC and other marginalized birthing people, the challenges that they face when they are pregnant, which can lead to an outcome that can be very devastating for all, because we know that stillbirth doesn't just affect the parents, but affects the community as well. So let's move forward with tools that can help. That part will be by Elizabeth O'Donnell.
Thanks, Marjorie. Hi, everyone. I'm Liz O'Donnell, Push's Director of Education, and I'm honored to be closing today's panel with you. In this last section, we'll be shifting from the why of the stillbirth crisis into some very practical tools and strategies that you can take back to your practice and your patients. Together, we will lower the rate of preventable stillbirth. This is designed to be an interactive portion, so please use the chat throughout the presentation. So to start us off, I want to know, what tool or practice do you most often rely on for fetal surveillance or fetal movement monitoring in your setting? And as you are sharing that in the chat, I want to let you know there's no right or wrong answer. The point is to see the variety across our settings. Every tool has its strengths and limitations. And so I just want you to get a good idea of what your colleagues and peers are already doing. And as you are sharing in the chat, feel free to also, create some dialogue, make some comments about what you're noticing. And as you are finishing up sharing that, I want to quickly talk about why this screening and education matter. So, fetal movement is baby's only language. And a very sudden increase or more excessive movement, and then, of course, a decrease in movement can all be early warning signs of distress. I always use my own personal story for this as a way to prove that education saves lives. When I was pregnant with my daughter, Aaliyah, who was born still, I had a very perfect textbook pregnancy. I was low risk. Everything was always great until it wasn't. And the truth is, while I knew that a decrease in movement was not a good thing, I had no idea about how a sudden increase or a change to more excessive movement can also be a sign of distress. I noticed a change in Aaliyah's movement on Thanksgiving Day. And again, I felt fine. I wasn't in pain. I had had a healthy pregnancy. I was a little over 32 weeks at the time. And I thought, Aaliyah is just matching my energy. Today is a holiday. I'm bouncing around all over the place, and so is she. Again, I felt completely fine. I didn't know that that increase in movement and that more excessive movement compared to her typical movement was a warning sign of distress. Had I known that, I would have immediately contacted my provider. And so that brings me to my point of how education on this saves lives. When families are taught to track movement and to speak up about changes, and when they learn about the types of movement that they might feel and what to do when it's different from their norm, providers have an opportunity to act before it's too late. And so in the chat, I would love for you to share for my providers here, how do you explain fetal movement to patients? And then for the parents that are joining us, how is fetal movement explained to you, if at all? Again, for me, I knew about the importance of contacting my provider if I felt a decrease in movement, but I never knew about the increase or excessive movement. And we hear that a lot from parents. So I'll give you a few seconds to share in the chat before I continue. So when we talk about standard tools for monitoring, we know that the non-stress test, or NST, is monitoring fetal heart rate in response to movement. It's a quick test, it's widely available, but it does have some limitations such as false positives, and it also is only looking at one variable. The biophysical profile, or the BPP, is combining an ultrasound with an NST, and it gives a score from 0 to 10. It's assessing breathing, movement, tone, fluid, and heart rate reactivity, but it does depend heavily on the operator's skill, and it's not reliably capturing acute events such as cord accidents. And I share all this to say, this is why we emphasize that no single test is perfect, and that the tools that we have work best when they are paired with a patient voice. And so if a patient is sharing that despite the results of these tests and what they may say, that they still feel like something is off or not right, providers, please, please, please believe them when they share this. Please believe them and start thinking about what other tools and tests you can do to find out, is there a source of concern here? When we talk about placental health, the placenta is the baby's lifeline, and we have some ways to make sure that the placenta is functioning the way it should. The first I want to share with you is EPV, or estimated placental volume, which is basically like a growth chart for the placenta itself. Again, I'll share a personal story. And this is why I am such a proponent of EPV personally, is that after Aaliyah was born still, I was immediately told that it looked interesting that the placenta was small, but I was told that because Aaliyah's growth was just fine, that there was nothing to worry about. I just happened to have a small placenta. I did not know, I was not educated on it. And so I just kind of went with that until I started to share that with others. I did some research, had some additional testing and placental pathology done. And in fact, the placenta was on the smaller side, and it absolutely impacted Aaliyah. And so had I known that, with the use of an EPV test, maybe we could have had some plan in place. I would have known, there is a potential risk factor here. Here are some things you need to look out for. But again, I just didn't know. If you are interested in learning more about estimated placental volume, I highly encourage you to visit measuretheplacenta.org. They have a lot of resources, research, and a ton more information on this emerging tool. Some other ways to monitor placental health are through the structure and the position of the placenta. We know there are a number of conditions that put pregnancies at higher risk when that structure and position are off. And then, of course, shape also matters. Research shows that very thin or very thick placentas can both be signs of dysfunction. And I think the best way that it was described to me by the doctor that I worked with when we, found out about Aaliyah's placenta size was he described it as the placenta being like a gas tank. If it's not functioning well, babies are going to conserve energy. There's going to be a change in movement. They're going to slow down. And again, the way it was described to me was Aaliyah was doing just fine, but she ran out of gas. The placenta could no longer keep up with her growth. And so again, for anyone that wants to dive deeper on this topic, I highly suggest Measure the Placenta, and you can find them at measuretheplacenta.org. So when we talk about some other emerging tools, when a standard test looks normal, but something still feels wrong, either for you as the provider and your provider instinct, or because the patient is sharing that they still feel like something is wrong, we do have some new emerging tools. And I would love for you, even in the chat, to maybe share if you're familiar with any of these emerging tools, or if you know of some other tools that I didn't list here. But we do have some blood biomarkers. They are adding just some new insight into early risk factors, preeclampsia, cardiac stress, risks for preterm birth. We also have some additional Doppler studies that are measuring blood flow resistance and are also helping us to assess that placental function, which we just talked about is so important. And then also kind of reimagining growth scans. So growth scans are most useful when we're tracking trends over time, as opposed to relying on a single percentile cutoff. And so again, I encourage you in the chat, please feel free to share if you've used any of these emerging tools, have any thoughts on them, or if you are aware of some that I didn't mention here. And I think it's important for us to mention that not every intervention requires high-tech equipment. Some of the simplest strategies are also the most effective in preventing stillbirth. So side sleeping, we know that supports a healthier oxygen flow. There's been a lot of recent research about CMV and the importance of CMV hygiene, which means an increase in washing hands and avoiding food or drink sharing, especially with toddlers, as a means to reduce the risk of stillbirth. And when in doubt, keep the patient on the monitor. The key is to build these strategies together and to really listen to instincts. That's both from you as the provider. If tests are coming back normal, but you still feel like something is off, please don't let that thought slide. Please see what else you can do to try to figure out the root of the issue. And as I mentioned before, if your patient is using their voice to share that they still don't feel comfortable, they still feel like something is off, please get them back on that monitor and work together to figure it out. And so feel free in the chat to share a prevention strategy that you always make sure to use or that you want to start using that you've seen be really effective. And I know some of you still might be sharing in the chat, but I want to take this time to just share some of Push's additional resources that we have for both providers and for families. So for providers, we have 2 accredited trainings that are available on our site. We have a accredited training for stillbirth prevention and an accredited training specifically for working with families who are pregnant after loss. And then education resources for our families, whether you are pregnant after loss, pregnant for the first time, and just want to be more educated. We have a lot of education resources for you on our website. And if you see a topic or if you know of a topic that we haven't covered and that you are looking for more info on, please do not hesitate to reach out and we would be happy to help point you in the right direction. And on behalf of the Push Pregnancy Director team, I want to say thank you so much for being here today, for being a part of this conference. As providers, researchers, bereaved families, together we can and we will end preventable stillbirth. And we are firm believers that it starts with real, honest, collaborative conversations like this to get that ball rolling. So thank you so much for joining us. You can find us at pushpregnancy.org. We are on social media at pushpregnancy, and we'll open it up for some questions and answers now. Thank you so much.